please continue to enjoy your lunch. We're going to go ahead and assemble here for our next session. It's just been so full of yes, please come, so full of really wonderful presenters that I'm sure this one will be equally, if not more, as engaging as the previous ones. But please continue as we assemble. I'd like to also give just another big thanks, another shout out to United Healthcare for the fabulous lunch that was sponsored. So we really appreciate that. Okay. Let me just start off by introducing our presenters here today. Many are long-term friends. Others are new faces that are part of the family now. All it takes is just one visit. So what we have on our panel today is Brett Edelson. Brett has been with the United Healthcare since 2005. He currently serves as Vice President of Product and is responsible for all aspects of product development, product management, and product operations for the 4.5 million people that the company serves in Medicaid and related programs. Prior to his current position, Brett served as Vice President of Children's Programs for United Healthcare, with responsibility for program development for the 2 million children that the company serves in Medicaid, the Children's Health Insurance Program, better known as CHIP, and specialty programs for disabled children. Next, we have Kim Nettleton. Kim Nettleton has worked in Medicaid managed care for the past 12 years and in the healthcare for more than 25 years. Kim has been with United Healthcare Community and State Division in numerous roles, including Vice President of Operations for the Texas Health Plan, Regional Director of Medicare for Special Need Plans, and currently serves as Director Strategic Solutions, Community and State, is the segment for the United Healthcare that focuses on Medicaid and low-income Medicare populations. Welcome and thanks, Kim. Next to her, we have Lynn Clay. Lynn has extensive experience in community organizing with urban communities, and he has over 20 years of HUD experience managing Hope 6, public housing, and neighborhood development grants all across the country. Before coming to HUD, Lynn worked with youth gangs, managed a few community development corporations in Philadelphia and New York, and created neighborhood strategies for acquiring tax-delinquent properties to be rehabbed for low-income renters and buyers. Next, we have Ron Ashford. Ron Ashford is the Director of Public Housing Supportive Services at the Department of Housing and Urban Development, HUD. His office is responsible for the community services component of the Hope 6 program, and since January 2005 has also been responsible for the Resident Opportunity and Supportive Services program, the ROS, which includes public housing, family self-sufficiency program. His office is now responsible for all supportive service programs for public housing. We welcome each of our presenters, and we thank you for really a robust conversation that we will have today that covers the spectrum as we deliver care to public housing residents and what that care includes with our partners. So thank you. Brett?
Yes. Oh, perfect. All right. All right. So first of all, thank you so much for the invitation to speak today. It's always an honor to be a part of the discussion, and at United Health Group, this is always something we take very seriously. The amount of trust that the public puts in us to manage these sorts of programs for the underserved is truly a privilege, and thank you for allowing us to be part of this. The health system has rapidly evolved over the past 10 years, and I know everyone in the room knows that very, very well. At United Healthcare, one of the ways we've seen it evolve is within what we call our patient or person care-centered model. And the first kind of question we usually get when we talk about things like this is why? Why is United Healthcare interested in this sort of evolution? And there are two main reasons. First, it's kind of the right thing to do, which no one's going to argue with. The intersection of housing, employment, social supports and everything that goes along with healthcare is coming together, has come together for many years, and is an acknowledgement of that. The secondary piece, kind of the business piece, when sometimes we get pressed on the question, it's because when we think in the Medicaid space, when we work with states to develop managed care contracts for those in Medicaid and related programs, this is part of the standard now. It's not just a healthcare program, it truly is a person-centered approach that involves all aspects of care, and our care model is very much aligned with that. So if we look on the screen, this is what we call the next generation of clinical care. And along the left side, we go through all of the core concepts of what we believe that means. And then on the right side, we put a finer point on that and talk about what that means for the Medicaid population. So I'm just going to provide a little bit of color commentary on this. So the first core concept is around patient-centered solutions and not being disease-focused. We know that the prevalence of disease, the knowledge of disease is incredibly important, but for every person, for every individual, that manifests itself in a very different way. And so the core concept number one is around that patient-centered, person-centered delivery that goes beyond the disease and true to the person and how that condition manifests itself with them. The second point of our core concepts is around the integration of medical, behavioral, and social care. We know that in partnership with our providers, with caregivers, with all aspects of the delivery system, that we need to work together to come up with the best support structure, the best clinical care program to help serve the people that receive their health care through United Healthcare. That picture in the center kind of demonstrates that, and literally you can see in the middle is a person. In the pictorial here, it's actually a person who's a member of ours. He is a member in Tennessee, and he receives services through long-term supports and services through our company and has been a member for a long time. That's literally the person-centered approach that we take for this individual, and we do across the continuum of care for all the people that we serve. The third core concept is around population segmentation and stratification. We know that we have access to a tremendous amount of data, and using that data in a very organized fashion to figure out how to deliver the best services at the right time is incredibly important, and that's why it's one of the core concepts that we deliver on. And then the fourth is around bringing together all the resources in case management, in health homes, and other types of integrated care organizations into a multidisciplinary team that gets at the root of the clinical condition and the other issues that are surrounding the individuals that we serve. And all this comes together in point number 5, which is kind of how we then transition to being applied to Medicaid, is that we then use real-time data sharing, so literally looking at ER data, admission, discharge, and transfer data to understand when those key care transitions take place and then doing something about it. And I'm going to illustrate that a little bit later on about how that actually works and why it's important to the system. So when we think about all those core concepts and then how they apply to Medicaid, those are those points on the right. And as I said, there's a little bit of a finer point on those exact same concepts. So when we think about patient-centered solutions, what that means within Medicaid is looking at whole person care. And it's not restricted to an individual facility, to an individual specialist or provider or a primary chronic disease. It is across the person, and we really do take that to heart. The second is knowing that the mix of services delivered to someone on Medicaid is much more community-based than it would be for the general population. And this includes coordinating services across social agencies, across housing, transportation, and every psychosocial need that an individual needs to ensure that all barriers to care and all access barriers are addressed. The third is the high prevalence of what we call superutilizers within our population. When we look across the entire population we serve in Medicaid, which is about 4.5 million individuals, there's about 1.5% of those that drive about 1/3 of the costs and the utilization within the population. And that constituency we work with a little bit more intensely to ensure that it's as well managed as possible. And the final distinct point within Medicaid is around additional focus on community health resources, like working with those who provide services like promotores and lay coaches and food stamps, federal qualified health centers, and many, many more. just going to fill this out. So on that point around the Medicaid community and who we serve, on the left-hand side, you can see very broad groups of individuals: pregnant women, children, adults, seniors, and those who are eligible for institutional type programs. You can see the blue, which is kind of the number of individuals represented that are kind of in that general population, that population that doesn't need the sort of intense support day to day that we talk about in that super utilizer population. And then in the rose colored and in the deep red, that's when we start to get into those very complex populations, that 1.4% that represents a little bit of a third of the utilization, and about the 5% that's a little bit over half. And what that means to us at United Healthcare within Medicaid is there's about 60,000 individuals across the 4.5 million people that we serve that we take a much more deliberate approach to understanding their health conditions and to ensuring that all the barriers to accessing care are coordinated and are addressed. And then that 5%, same thing, it's about 200,000 people. So that's not to say that the other 4+ million, we don't take it as serious as a role, but it's a little less complicated when it comes to those individuals. And then we apply this graphic on the right of how we improve health for the Medicaid population across behavioral, medical, and social. And we literally harness the community in that effort. We know that it isn't one individual case manager from our company, one individual physician or specialist or provider or nurse practitioner or community health worker. It is the entire system that's needed for those individuals, and we help to coordinate across all those areas. So how does this kind of get operationalized? The picture at the top is obviously the United States, and the states that are shaded in blue are the states that we today serve Medicaid managed care populations in. It's about 25 different states. So the way this works, if you look at the 3 dots that we show in Texas, Arizona, and Florida, we show that how we kind of do what we call locally hot spotting individuals. So literally we'll look in all of our data and understand the prevalence of disease, of conditions, of things like housing shortages, of barriers to healthy food, and then pinpoint it to literally a neighborhood or a community. And Kim's going to talk a little bit more about this when it comes to housing. We then identify those hotspots, and you can see then in that middle graphic, we look by zip code, by clinic, literally the clinics that our individual members are seen at, and then by subpopulation within our membership. We then kind of pop out who those super utilizers are to then ensure that you can see the individual at the C, how we then coordinate care across all of those individuals. And then we take that person-by-person approach, again, the same graphic you've seen on the other slides, to ensure that we are addressing the individual's needs to their individual health conditions, to the individual barriers to care. So how this works, we're going to use an example of a fictitious individual named Lee. And Lee has chronic back condition. He also has drug-seeking behavior, and we've been able to identify this through ongoing analysis. Now we're going to show you kind of what happens when we don't coordinate care. Essentially, you can look across the first time that we know about Lee is when he is admitted to an ER, he goes to the ER and is admitted to the hospital because of back pain. We then know that he has a hospital admission because of that back pain when we then realize that he has an acute diabetic episode. He then goes back to the community and he has a series of ER visits for his back pain and some additional hospital admissions for a painkiller overdose. And this uncoordinated approach, again, where we don't want to be, but that uncoordinated approach leads to very much episodic care. It leads to lower outcomes when we think about pharmacy adherence, higher use of ER, higher hospital admissions, and literally you can see woven throughout this isn't a single instance of behavioral health care. So when we apply our patient-centered care model, Lee has a slightly different experience, which we think leads to much better outcomes for the individual. So it's the same individual named Lee, but our care coordinator has been assigned as soon as Lee becomes part of our health plan. And then Lee, he through a health risk assessment. It's identified that he does have drug-seeking behavior, so we work with him so he can go to the care facility, and then you can see all the little individual instances of C, our care manager, is places where they intersect. After they're in that care facility, then we have more follow-up, more support. We want to ensure that they have follow-up care. Lee has follow-up care with a behavioral health counselor, so you can see the pictorial of a car. We ensure there's transportation so he gets to that behavioral health specialist. We then ensure that the PCP program starts. And again, we ensure there's transportation, and you can see our caseworker again following Lee throughout the program. We then ensure that the behavioral addiction is addressed. We ensure that the patient sees a nutritionist because we know he's a diabetic. And then finally, that Lee is part of a long-term viable housing solution. And that is kind of where the story ends. So you can see it's a high-level picture of what we do, but we use the same data. We use the care coordinator, which is literally someone that Lee's going to know face-to-face, someone who's going to be in their home, somebody who's going to be a part of Lee's life, somebody that may go to the hospital or a provider visit with him to ensure that all these things happen and all those barriers to care, whether it's transportation, housing, food, are all addressed in concert with that care plan. So we view this as the patient-centered care model, a much more deliberate approach to ensuring that access barriers are reduced and access to care is increased, thereby having better outcomes for all the individuals that we serve.
Thank you.
Good afternoon, everyone. Good afternoon, that's good. So just to let you know, we're sitting here and you know, sometimes you go and you hear music and the lights are on and you wonder if they can see you, the musicians can see you. We can't see you at all, right? So there's a light out there. I'm talking to the light and I'm talking to the camera out there. But I know you're out there and I appreciate this opportunity. So I'm from HUD, and as Karen mentioned, I'm the director of the Office of Public Housing Supportive Service Programs. And there are a lot of changes going on at HUD right now. As I'm sure many of you know, Sean Donovan, our secretary, is leaving. He's going to OMB. We have a new secretary who's about to come in, Mayor Castro from San Antonio. In the public housing world, our assistant secretary, Sandra Enriquez, is leaving and somebody else is going to be coming in. And this is actually all part of what happens in government towards the end of a term. People leave, new people come in. So there's all these changes afoot at HUD. So we work in public housing, but one thing we know that hasn't changed, and that's the health of public housing residents. So yes, there are changes here, but on the ground, public housing residents, the situation has not changed. 10 years ago, we were working with Urban Institute, and they surveyed some Hope 6 developments, and they had 50 questions, and they found out X, Y, Z, and they came back and they said, we really didn't learn a whole lot. But here's one thing that we were struck with, that the health of public housing residents is so bad. Using as a barometer Black women across the country, diabetes rates almost twice as high. Depression rates almost twice as high. Obesity, hypertension, almost twice as bad. So that's the situation 10 years ago. And I'm pretty sure if we were to do that survey, or Urban Institute were to do that survey today, they would find that the rates are just as bad as they were. With the exception, I hope, of residents in developments that are close to yours. Is that true?
Yep.
Whoa, that's not good. Isn't it true that residents that are served by your FQHCs, that their health is better than, yes. Thank you. At least this table gets my star. Thank you very much. Okay. So we have to change that some way, right? So HUD is in the business of housing, right? Our office is actually an anomaly. right? We're the Office of Supportive Service Programs. We actually, HUD and housing authorities by and large, really don't do supportive service programs. We partner with other people, right? So at HUD, we have a grant program, the Ross program and the Family Self-Sufficiency Program. The Ross program funds service coordinators. So it used to be that it would fund job training programs, et cetera. Not anymore. We fund a service coordinator to connect our residents to outside programs. Same thing with the Family Self-Sufficiency Program. We fund efforts to connect to other programs. What we've done in our office is we work with Department of Justice on reentry issues. We work with Department of Labor. We work with NIH on With Every Heartbeat is Life, which Len is going to talk about. We work with other agencies to move the dial, right? That's what we do. But one place, obviously, that we have not been able to move the dial on is the health of public housing residents. We have tried to get more FQHCs involved in public housing, and for some reason, we can't get traction on it. We don't know why that is, but we know that in order to change the lives of public housing residents, we need to begin to get traction. And I believe that you are the answers. I understand that there was a session before lunch where residents of public housing served by you testimonials about the changes that were going on in their lives because of the programs that you run. So what I'm going to propose to HRSA is that we jointly put out some materials. We jointly put out bulletins and brochures which speak to the successes that you have and the successes on the lives of public housing residents, and begin to push this out. Push it out to other FQHCs that are not now serving public housing residents, to the lookalikes who are not now serving public housing residents, and up the scale, up the number of agencies that begin to work with public housing residents, so that 5 years from now, when we do those surveys, we can find that the health of public housing residents is not twice as bad as those of black women across the country. So I'm going to be here throughout the afternoon. I would love to talk with many of you. I would love to leave here with a list of housing authorities that say, or FQHCs that say, yes, include me on that brochure. Here's my contact name. And we got some residents who would also love to be part of that, so that we can compile this and we can get this out and change the lives of public housing residents. Thank you. There's no lights here, so lights.
I know. Ah, touche.
Let's see. All right. Good afternoon. I'm excited to be here. She said my name is Kim Nettleton, and I'm with United Healthcare. I work with Brett, and we work with the sorts of members who have Medicaid or have Medicare and Medicaid in our low income. Populations in Medicaid managed care in the past, states have typically been their TANF, their assistance for needy families, basically pregnant women and young children. But in the last few years, states more and more have been adding additional populations to their Medicaid managed care programs. Those have included folks who need long-term support and services in order to remain successfully in the community. It's now beginning to include folks who have severe mental illness, intellectual development disabilities, a variety of different populations. In addition, with the expansion of Medicaid managed care, we are beginning to see more and more, particularly sometimes because of the support of agencies and organizations like yourself, folks who have been chronically homeless who are beginning to apply for Medicaid benefits and are beginning to show up on our health care plans. States are also trying to meet Olmstead and other ADA regulations, where they're trying to help folks who have been institutionalized, who don't need or want to be institutionalized, to return to the community. And those have all been populations that they've asked the Medicaid managed care plans to help outreach to and to support. So when MCO organizations are invited by states to participate, they are usually invited to do so through a response to a request for a proposal. Medicaid is a federal and a state program. And so the state will decide the populations, the geography, the benefits that will be included, and they request CMS to approve those waivers and services. It can be a very delicate dance between the states and CMS to determine what types of things can be covered and how they can be covered. Most MCOs work on what we call an at-risk process, where states pay us a certain amount of money per member per month, and we are obligated to help ensure that they receive all the services that they need, and we're at risk to try to stay within that dollar amount. In addition, states have begun to add other benefits or services where they're measuring outcome or quality goals. In some states, Kansas and Texas, for example, there's a 5% premium withhold, which can be significant dollars if you don't reach those particular quality outcomes. In other states, their quality outcomes can influence membership ability to join a health plan, or it can influence the ability to earn bonuses that are available. You can imagine the difficulty at focusing on mammographies and immunizations for someone who is either living under the bridge or who is couch surfing from friend to friend, neighbor to neighbor, and worried about where next night's bed and the next day's meal is going to come from. We have identified that healthcare is no longer just a matter of hospital services, provider services, even long-term support services. It's really making sure that those basics are covered. We talked about the patient-centered care model in some in-depth. Again, this is a matter of providing the right care at the right place and the right time. And a lot of that is beginning to start to look again at site-based care. So how can we be involved with students to make sure that they get their immunizations when they spend how many hours a day in a school setting? How can we help make sure that folks that have no transportation and that are having difficulty accessing their appointments and need additional support to help manage their diabetes? Is it perhaps at their housing site that we can do that? So how is United taking a look at this? We're really doing it in 4 core areas. One of those first areas is in policy and advocacy. It's taking a look at where can we help influence policy, where can we advocate for changes, where can we say HUD and CMS and HHSC, where are the opportunities for us to braid funds, to work together on pilots and programs, to show the impact that we can make when we work together. Where are the opportunities for us to help build capacity? UHG, our investment finance team, has been active in investment tax credits for low-income housing for several years. Now we're looking at how do we leverage that. How do we not only help build the capacity to bring more sites on site, but how do we work with our Medicaid members then to be able to take advantage and be a part of that? We've talked a little bit about the clinical care model. So what are the questions that should be added to that health risk assessment? How do we determine that somebody is precariously housed? How do we determine that the only place that they can buy groceries is the local 7-Eleven? And what impact does that have on the model and the decisions that we help them to make and the resources that we help bring to them? We're looking at how to apply assistance to the folks, okay? How do we understand? How do we help a service coordinator or a care manager understand what a voucher is and what the voucher situation is in town? How do we let them know about the continuity of care programs that are going on for those folks who are homeless, and how could that affect our members who are chronically homeless? What should be done differently when it comes across the state Medicaid file and the address listed as a homeless shelter? So how do we get involved in working with those homeless shelters, and how do we help make those next steps come together? And then finally, we're really looking for on-the-ground pilots. How can we put together all of the advocacy and the policy and the theory, put it into action, measure before and measure after, and then say, here's what we got out of it, and how do we scale it? And so we're looking at a number of different types of pilots, working with partners that we never even knew existed in many cases. I have a service coordinator that has been seeing a member at a permanent supportive housing site. She said, I've been seeing this member for 2 years. I've been in and out of the place probably 6 times. When we identified that it was a permanent supportive housing site, she met the social worker and the resident manager. She saw the list of activities and services that they provide, and she said, who knew? Who knew that we could be working together, that I could help my person here who is struggling with diabetes control by saying, did you know they have a walking club? Let's go talk to the resident manager and see what it would take to get involved with that. Did you know that there was access to transportation to get to the AA meetings? So it's really looking at new partnerships and new opportunities and then measuring those results. The opportunities for engagement really vary according to the population. When we think about that TANF, that healthy pregnant women, families, young families type of population, we actually have programs in United where we partner with 4-H or with Sesame Street to work on eating healthy and making healthy nutrition choices. We have Dr. Healthy Hound who can work with students and talk about physical education, being active and being involved in the program and making that a family affair. So there are programs that we can bring to the site that would benefit our members, but benefit the health of the entire community that are there also. We can help with those folks who are elderly or who are having special needs to stay in the community, that are looking to try to age in place, and look at the types of services that we can bring to them for that. What kinds of services do they need brought to them? Are there greenhouse programs going on that we can support? Can we support nursing facilities who are having folks moved out because of money follows the person to transform themselves into these villages that can really support people aging in place and yet maintaining their independence? If we look at folks who need long-term support services, the whole idea of permanent supportive housing and the providers and the services that are around those, it's embracing how do we identify them, how do we work with them, how do we fund them when that's the appropriate thing to happen for our members. We've called out homeless as an individual population, but when you think about all of our populations, we have folks in our plans right now who are chronically homeless or precariously housed. But this homeless population, this chronically homeless population, is a growing new population that we're going to be addressing in the future also, particularly in states that are expanding Medicaid. And so it's taking a look at that population and saying, what are the special needs that we have to do? How do we support housing first? How do we support harm reduction and make sure that the first thing we do is get them housed so that they have the ability to embrace the other services and benefits that we can bring together with them? And foster kids is another group that is beginning to show a really new population that really has some unique requirements. And as they age out of foster care, the numbers of them that can become homeless is pretty significant. So how do we help prevent that from happening instead of just reacting to it after it does? So what are some of the specific pilots that we're taking a look at? One of those pilots is in Austin, Texas. We actually, through our UHG investment finance team, helped to do a tax credit investment to help build a new site working with Foundation Communities. It is a 147-bed unit, or apartment unit. 36 of those units will be dedicated to people who are chronically homeless. In our long-term care and support plan in Austin, we have over 1,800 members who are unable to locate. We can't reach them on the phone. They don't respond to certified letters. When we drive by, we can't find them. We are working to contract with the Homeless Coalition there. They will help us to take a look at these members. These 1,800 generated over $6 million in claims in 18 months. The top 25 generated over $2 million in and of themselves. If we can identify these members, the ones that may be chronically homeless, if we can take advantage of the work that is going on through the continuity of care right now, and we can get them housed in October when Foundation opens these new sites, we have an opportunity to not only reduce costs and improve quality, but to really change lives. So that's one of the pilots that we're taking a look at. Another pilot that we're taking a look at is we are working with Christian Church Homes. They have a tower that is dedicated to seniors and persons with disabilities in Houston, Texas. That tower had some damage during Ike, and they have been in a planning grant stage where they are working with the city, with a number of different foundations, with the Housing Authority. They are building a community development team that United is a part of, taking a look at this. This tower is in a zip code where we have over 1,000 members of all the different types of Medicaid plans that are there. It's a medically underserved area with a behavioral health crisis in that particular area. So bringing an FQHC in and putting it on the ground floor of that site will be a wonderful opportunity to not only serve the residents, but that entire community. And by bringing the folks in that community that serve it now together to identify those needs up front, one of the needs that we identified was the potential of including a medical legal partnership as a part of that clinic. So we're really starting with the planning stage of looking at what that community needs and hoping we can grow from there. So those are some of the exciting things that we've got going on right now, and we are looking forward to perhaps in the future being able to come back and share some results. Thank you.
Hello, how's everybody doing today? Yeah, I think I'm feeling all right too. I'm going to really try and talk to you about a movement, because the kind of issues that confront us, the kind of challenges that we face, are really about putting together a movement to address public health concerns in this country, and particularly among low-income populations, marginalized populations. And that's important. I'm pushing these buttons. Is this it? Okay. I wanted you to just look at some of these statistics, because if I'm going to talk to you about a movement, you probably need to say, well, what is he talking about? Why? Something else you might want to think about is the fact that the federally qualified health centers grew out of a movement. They grew out of the civil rights movement. That's right, the civil rights movement. Back in, what is it, 65. Boston, Massachusetts, and Mississippi, Mount Bayou. And the idea that health was an important part of the civil rights movement. They don't look very good, do they? These are real statistics, and they've probably gotten worse, if anything. This thing about stress, mental illness, and poverty, how does that work? Well, your body releases something called cortisol. And it normally releases it when you're in a terrible situation, because you need to get your act together, so to speak. But if it releases it continuously and consistently, and you're always responding, that becomes almost like a poison in you. And the more it does that, the less you have the ability to think logically, clearly, consistently, and concisely. And this happens when you most need it. So you end up making poor decisions, bad decisions. And this has been demonstrated around the world, and I've put down this is a book called Poor Economics, this guy, Banerjee and Dufault, who spent a lot of time looking at that situation. And this happens all across the third world. This is where they say why people in the third world can't get ahead. Well, hell, people in the first world, this world can't get ahead because of that. Because you're stressed out, you have no support, and you get stressed out because you can't help your family. You can't get a job. You almost have one, but you can't. You don't control your housing because it's not your housing. And yet you're faced with all these critical decisions you're supposed to be making. What insurance should I be looking for? How do I go through the networks and find out how to get into the Affordable Care Act? When you think about it, it's almost laughable, because it would be an easier situation if you had a movement. If you had a healthcare movement, people would be working hard to make things work for you. You wouldn't have to fight for their attention. Even if you think about things now, suddenly there's health available, and a lot of people want to help you because they can be paid for helping you. The Affordable Care Act puts out a lot of money and creates a lot of opportunities. And I'm not saying there's anything bad or good about that. It's neither good nor bad. It just is. What it becomes up to you. And that means that you have to get active. If you're federally qualified health centers, you have to be very active about how you interact and relate to community groups, to public housing residents. Because I know I've had experience with federally qualified health centers that have not been as helpful as I would like for them to have been. And I'm not really talking about me personally. I'm talking about in cities where I have the With Every Heartbeat is Life program, and where the residents couldn't get the help they needed from a federally qualified health center. Just for fundamental and basic things that they really, really needed. Premature mobility. This is a very important little thing going on here, because what this really says is that a large amount of what causes premature mobility is about behavior. Obviously, a large part of it is genetics. You can't do anything about genetic predisposition. But a lot of it is about how folks act. Another way to look at it is to say it's how you relate to food. What is your relationship with food? Besides eat it. That's an important thing to think about, because food in large measure controls a lot about how we look at things, how we feel about life, and how we interact with life. Stress, mental illness, and poverty. That's the thing about the cortisol. Why do I keep going backwards? I'm going backwards because y'all don't have a movement. If y'all had a movement, this would not be happening. They would have this stuff together. I want to go forward. Okay. What did you do? HUD and NHLBI, National Heart, Lung, and Blood Institute, NIH, which is a group where With Every Heartbeat is Life resonated from, where it came from. Behavioral change, here we go again. What is With Every Heartbeat is Life? What are the goals? Change behavior, thinking and research supporting human behavior change. Organizing, engaging residents around With Every Heartbeat is Life. First of all, what is it? It's a train-the-trainer program, and that means that we train residents, public housing residents, and they train other residents. And we happen to know that the best way to change behavior among any group is to have people who are from that group change the behavior. I know it's good to have a doctor coming. We all want the doctor when we have that's the situation. But since a lot of it is about behavior, why not have your neighbor help you with the behavior? I mean, people learn from those who are close to them. People don't talk about obesity, diabetes, and hypertension with strangers. That's a cultural thing about how you sit down and eat, where you buy your food, how you cook it, how you socialize. The people who are going to influence you in that arena have to be folk who you feel good about. Now, let me be very clear. We're talking about community folks. But we're also talking about community folks who can focus, who are willing to learn, who are willing to be trained, and who understand the ability, and who have the ability and the will, if you will, to be rigorous in the work they do. I'm not talking about, well, we meet a little bit, we meet at maybe 3, maybe 4. No, we're going to meet at 3, we're going to do this, these are going to be the outcomes, this is where we're going to be, this is the baseline, we're going to measure this stuff. And the reason we're going to be like this is because this is how you get paid for doing what you're doing. Foundations won't give you anything if all you can tell them is anecdotal information. Well, yeah, we did this, and she lost 10 pounds. Well, where did she start? We don't know. When did she start? We don't know. What is she eating? We don't know. Does she exercise? We don't know. That's not helpful. People will pay you when you can put together a research design, and you can do this without having a PhD. You just have a baseline, the activities, how you intervene in your life, and what the outcomes are, beginning and an end. It's a story, and you tell your story. It really is that simple and yet that complicated. Because remember, what did I say at the beginning? This is about behavior change. That's not how people operate. People don't think about it in terms of, what did I do to get here? Why am I here? All they think about is that something went wrong. They don't like me. Something I did wrong. Like when I said, y'all have a movement, I wouldn't have had this problem with this thing here. But that's what we're talking about. It's about behavior change. And the reason that's important, and it's really a big reason, well, prior to the Affordable Care Act, 95% of all the healthcare dollars were spent on something called disease. That is, when you were sick, people would see you. Well, the Affordable Care Act, one of its main things is about wellness, which means we want you to change your behavior so you don't get sick. That's a big thing. Now, if you just think about it. If I'm a business, then I have to change my business model. This means that I'm not going to just come up with the prescription for how to fix you when you get ill. I need to think about, how do I work with folks to get them to change their behavior? Because that's the hardest thing out there. That's the difference between folks who finish high school and who don't finish high school, who start college and don't finish college, who take a course here and don't complete the course, who start a relationship here and don't do anything with it over here. It's about behavior. It's about what's important in your life. And it's really not about tough love and something called, I know people talk about, well, tough love. You make it tough, people will get it. Sometimes it's about thinking differently about things, and that requires rewiring the human brain. And I'm not a psychologist, I'm not a psychiatrist, but I do know about mental illness. And there are some that you can treat with medications, and there are others that you can only treat with behavior change or types of therapy. Usually they call them dialectic therapies, where you have a pro and a con, and you learn how to start making decisions about things. And this is a very heavy kind of thing to do in, if you say, the hood. But these are the kind of decisions that people who are marginalized, whether you live in the trailer, the barrio, or the hood, if you feel you've been left out, you have to start understanding, how do you start thinking about things in a different kind of way? The idea of, you can prevent this by changing your behavior. And the more you do that and the more you document it, the more you have a story to tell, the more folks will gravitate towards you. Problems are not being solved not because people don't care. They're not being solved because the right people haven't come to the table yet. And the right people, in large measure, are low-income people around this country. Black, white, and brown. And I say that in a very serious kind of venue. I don't say it as a way to rah-rah the crowd, because I don't believe in rah-rahing anybody. I'm saying that because it's hard work. Because if you want to take the leadership role, I'm talking about low-income people, want to take a leadership role, you have to do your homework. And you have to have partners. And that's why I like this program, With Every Heartbeat is Life. Because it starts with a basic partnership between public housing residents and housing authorities. And that has to be brokered very carefully about who does what, when, where, why, and how, and what the outcomes are. Because you want a real relationship. People say, I have a partnership. Bullshit, pardon the expression. Most people don't have partnerships. They just have I'm going to use you today and you use me tomorrow. That's not a partnership. A partnership are two people trying to grow towards more than what they have today. And that means both folks learn more and do better. And that means everything improves. And that means we take the whole relationship to the next level. We've all been playing on the same level for too long. That same pitying level. And it's not about whether you're educated or not educated. It's just about people like to play where they feel comfortable. And the only people that can really change that game are the people who are most in need. And unfortunately, the burden falls on the people who are most in need. That's who it falls on. It fell on them with the civil rights movement. And it's fallen on them with this movement. Other people cannot rescue you. If you have a broken leg, a physician can heal your broken leg. But other people can't tell you how not to have a broken leg. You have to work that out, and that's about behavior change. These are program goals. The big one there is about collaboration. And that's big because what I've found, I don't have any evidence based on this, but what I've found is that when you can help someone, you help yourself. And when you help yourself, you can see things. That's my time, isn't it? That's all right. I'm gonna do it in 1 minute. And when you can see what needs to be done, you can generally do it. And that's the message you want to take from here. You need a movement so you can see things that you can't see from where you are. Because if you can't move around, you can't see anything. So you want to be able to move around. Thank you.
Thank you. You know, I was sitting here, really, and my heart started racing. I'm just really pleased and delighted for both, all, Brett, Kim, Lynn, and Ron, that you share and that you care. That's the main thing that I hear. And when others care about a mission that is so important to all of us here, and that mission being raising the bar of the standards of healthcare for those that are residents of public housing. You know, I also thought about one person that I've admired for a number of years. She has a quote that I often use in a lot of presentations. When Shirley Chisholm was running for president, she had a quote that she said that service is the rent that we pay to live here on earth. And so all of us are about a service of caring. And so I just really want to, at this point, say thank you, really, from my heart, that so many people care about those who are voiceless, that don't have a voice, and we're that voice for them. So thank you for participating in this session. I think we've got a few moments now for a little bit of question and answer. Is that right, Jeanette? Okay. All right. There are some mics floating around, so please, if you have any questions that you have for our panelists, don't hesitate. Oh, yes, please. I'm sorry. They're right. This is like sitting in a movie theater. I really can't see anything out there, but I do see one person moving, and Devin has a mic over here.
Here. Hello?
Yes.
Oh, it's me, Karen, Diana Ray.
Okay.
This question is to HUD, and I'm wondering, why is it discouraged that residents in public housing that have to do their community service with the Quora, why is it discouraged that they cannot participate in healthy community classes, Zumba, walking clubs? That's not part of what they get credit for to do community service. I think if more residents were able to do something like that, I think you'd get them more involved and want to participate and stay in the program. So that's my question.
Okay.
So somehow this goes on.
Yeah.
So we know that different housing authorities have different community service requirements, and some of them are strictly you have to be in a job training opportunity, in a job training class or in a job training program, period. But other housing authorities have what you're talking about, have service, the resident council has service opportunities. I'm not sure about Zumba clubs. I have to look at that, right? But I know that they try to involve residents in the life of the community, and that requires the community service requirement. I will look into Zumba, but that hasn't come past my desk. So we'll investigate that.
Okay. Is there another question? Oh, yes, please.
I'd like to thank the panel, actually for being diverse enough to respond to a lot of the things that I came to find out from this conference, and I'd like to have all of you as cards. Okay.
Thank
We can
you.
use it in DC.
Very good. Any others?
In Philadelphia, Virginia Sprague, Philadelphia Housing Authority, we do with our every heartbeat there's life. And just one thing that's interesting, we have a challenge. We're trying to do smoke-free public housing, and we've got the three-prong attack: protection, which is the rule; cessation to help residents stop; and prevention to keep our kids from starting. But when we do the advertising, the flyers, and door-to-door, and try to get people to come to the smoke cessation, we don't get a good turnout. But when it comes through with every heartbeat there's life, you'll have somewhere around 30% of our residents who come are smokers, and then we'll have the cessation program there. And that's been the way that we are able to work with the health department and the CDC and meet our outreach objectives through, and you just wanted to share that with you.
Thank you for sharing.
Thank you. A couple of questions for United Healthcare. One from a contractual point of view, and this is experience we're finding in Illinois. More and more we're finding that managed care contracts are separating the contracts for their behavioral health from their primary care. Just want to make a statement that runs contrary to the Bureau's mission of providing coordinated behavioral health in primary care. And it becomes very difficult for us to provide care in a seamless way when you can provide primary care and you don't have a contract for the behavioral health. My second question is relative to your policy, and what your policy is relative to advanced practice nurses. They're being able to handle and manage panels on their own, being able to be contracted with. Can you speak to that at all?
First of all, thank you. Can you hear me? Thank you for the question. I think they're both really interesting tangents and have applicability to the discussion here. First, on integrated behavioral health, we absolutely prefer to work in communities where we do have the opportunity to integrate the care, and whether that's virtually because the state has separate contracts and then we kind of make a proxy for that by the way we deliver our care, or through those truly integrated programs. We recently implemented a program in New Mexico called Centennial Care, where literally it's every aspect of the delivery system that's a part of that Medicaid managed care contract, and we think that's our sweet spot where we can do the most good for the community. On the second question about policy on advanced practice nurses, to be completely honest, I don't know if we have a formal policy or not. I know that when we look at contracting with health centers, oftentimes the primary provider is an advanced practice nurse practitioner. We also employ nurse practitioners to go out into members' homes to do assessments, to close gaps in care, to do some other activities for those who have some of the most chronic conditions within our population.
I think there's one in the back.
This is along the same lines for United Healthcare, and the question's for Kim Nettleton. How the strategic solutions that you've mentioned in the brochure, how do you contact that, or how do you access that? And is that a national program or only a state program in Texas?
It's actually a national group. We are a segment of community and state employees that report up to Brett. And it's a group of us that work across the nation. We are telecommuters, so we're housed in all kinds of different states. And I'm actually working on housing programs in a number of states, not just Texas. Texas just happens to be a little more advanced because the state legislature added housing assistance to the contract for the Medicaid plans there in Texas. So they're a little bit ahead of the ball game. But we are statewide, and I'll be up here after this and have some cards here, or you can contact us through the folks at the organization or the meeting tonight.
Okay. Well, we want to just say thanks. And I wrote a few bullets, not a couple, but a few bullets that kind of cemented the synergy that was up here. Patient-centered medical home, business model, partnerships, better coordinated care, changes, and I love the quote of Florence Nightingale. I'll have to remember that and add that to my repertoire. Best practices, foster care, poor economies of scale. And then I kind of concluded all that with tell the story, which is what we hear, is tell the story. And that begins with all of us. So thank you, and we'll take a break before our next session.